Hello, good morning, everyone. Today I'm going to talk about the pharmacology of local anesthetics and introduction to it. Okay, before that, I request everyone to visit my website www.painfreepartha.com and can see my slides. Or you can also subscribe to my YouTube channel, Painfree Partha. Local anesthesia was accomplished by having the operator chew the cocoa leaves and apply the macerated pulp to the skin and wound edges while using a tumi knife to bore through the skin. Now what happened? The cocoa leaves, once what happened, cocoa leaves was chewed one by a person for this euphoric effect. But he got numbness. Then what he did was he opened up and removed the pulp, what he chewed, and pasted in the hand. And sometimes later this became numb. So all these things said, cocaine has got some properties, or cocoa leaves has got some properties with regard to dysphoria, pain relief, and also has some effect on local anesthetic actions. This was used. Cocaine, brachylepis, animal epidurals, fraud, and color. There are a lot of reviews on cocaine. Now you see pethidine, phenergan, all these drugs, promethazine, all these drugs have local anesthetic properties. Saxitoxin, tetrodotoxin from fish have also got local anesthetic properties where the receptor site is different from what the local anesthetics target. Now you see, started from 1884, and you see the levobupivacaine was in 1999. After that, nothing. So many drugs: cocaine, procaine, lidocaine, tetracaine, chlorprocaine, mepivacaine, prilocaine, bupivacaine, etc. So now we have lignocaine, bupivacaine, ropivacaine, and levobupivacaine here, and some countries also have tetracaine. What is the basic structure of local anesthetics? Local anesthetic drugs are water-soluble salts of lipid-soluble alkaloids. They are water-soluble salts of lipid-soluble alkaloid. There are three parts: lipophilic aromatic ring. This is an hydrophilic amine. There is an intermediate chain. This intermediate chain can be either ester or amide. That determines whether it is an ester local anesthetic or an amide local anesthetic. You can see the lipophilic part and the hydrophilic part. Again, you can see this is the benzene. This is the COOO is what is that? Ester. CONH is amide. So this is the ester local anesthetic and this is an amide local anesthetic. Now what are esters? Cocaine, procaine, chlorprocaine, tetracaine. These are some of the esters. How to remember this? There will be two I's in amides. Amide, lignocaine, mepivacaine. Caine there is one more I here, one more I here. So two I's form amides. Only one I form esters. This is the basic difference between amide local anesthetics with regard to remembering those. Unstable bonds and allergic potential made this ester local anesthetic slightly out of favor. That is what is the difference. Ester local anesthetics have gone slightly out of favor because of the possible allergic potentials. Now we have lignocaine, bupivacaine, prilocaine, etidocaine, bupivacaine. All these see here I. Now again I'm telling you, this is the CONH, amide bond. This is lignocaine, amide local anesthetic. Now you can see ester bond, COO. This is procaine. So now we have lignocaine as amide. Amide means what? CONH. Ester means what? COO. So this is ester and this is the intermediate thing. That is what determines whether it is an lignocaine or procaine. Ester, local anesthetic, or amide local anesthetic. This tertiary amine, this is tertiary amine. The side rings, this is a benzene ring. These don't change for ester or amide. The esters are metabolized by pseudocholinesterase and short action usually, and PABA is the end product. Because of that, a possible allergic reactions are there, and cocaine is hydrolyzed in the liver. That is the difference. Now you turn to pharmacokinetics, they are go into as PABA. This can cause a possible allergic reactions. Now we have articaine. Now you see CONH is an amide local anesthetic. This is an amide local anesthetic because the intermediate bond is amide, but it has got an ester here. So if you have an esterase cleaving this, then this drug will become inactive. So that is what is this about this articaine. Even though it is an amide local anesthetic, as this is cleaved by the esterases, it becomes inactive. This is the difference between the metabolism of other amide drugs and articaine. The aromatic ring, what we saw, the benzene ring, no, that is lipophilic. Lipophilic means lipid liking. Membrane is full of lipids. So that means the potency of the molecule. We can also call it hydrophobic or lipophilic. More lipophilic, it is more potent. That is the basic funda of a local anesthetic. Samaritan, this drug has mixed characteristics, local agonist plus mu opioid partial agonist. It is structurally similar to pethidine. That is why, even though it is a local anesthetic, it has got a partial opioid agonist activity. Senbucridine is a non-ester, non-amide. This was there when in 1990s and became out of this thing. It was actually from India. So senbucridine and samidine are two different local anesthetics with different properties, but currently not commercially available. Now we have what do you know as the relative potency. Potency is low procaine. Chlorprocaine is also less potent. You see here, etidocaine, bupivacaine is very potent because the lipophilicity is very high. Lipophilicity is otherwise called hydrophobicity. Now we can see there, lipophilicity high, bupivacaine more potent. That is why we need 0.5% bupivacaine, 0.5% tetracaine instead of 2% lignocaine. That is the difference between the potency or lipophilicity of a local anesthetic. Procaine 4% solution. See, lignocaine 2% solution. Bupivacaine 0.5% solution. Sometimes substitution of the aromatic ring. Aromatic ring is there, no? Substitution, ethyl group, methyl group, butyl group, something like that can change the lipophilicity. And molecular weight, what does it happen? Yes. The smaller the molecular weight, the more rapidly molecules diffuse. So here, there's a small difference. It's around 220, 230 range, and it is around 275 to 88 range. The bigger the molecular weight or the more the molecular weight, the possible entry through membranes is little less. Ropivacaine has no asymmetric atoms and no enantiomers. Now we will go to the pharmacokinetics. Onset. Now this is the insoluble base. It combines with an hydrochloride and forms an hydrochloride salt. That is what I told. This is what local anesthetics are: water soluble salts of lipid soluble alkaloids. First slide I showed, these are all water soluble salts of lipid soluble alkaloids. So this is an hydrochloride, lignocaine hydrochloride, bupivacaine hydrochloride. Local anesthetics are weak bases. They are hydrogen acceptors. This nitrogen tertiary amine will become NH plus. This NH plus is called ionized. I have already told what is a base, what is an acid. A base is a hydrogen acceptor. An acid is a hydrogen donor. This is I have in acid base another YouTube channel, another YouTube video. So this is an ionized. This becomes unionized. The unionized portion is lipophilic. It will enter the membrane. but it has to be prepared as a hydrochloride solution. To make it as a solution, you cannot put fat droplets into the nerve, no? You have to make it as a solution. So hydrochloride salts are made. Now, base unionized lipophilic part is membrane liking. This part has to be more if the drug has to have a fast onset. Yes, the drug has to enter here. That means these membranes are lipids. So it has to be lipophilic. So the unionized portion has to be more. The lipophilic portion has to be more to enter the cell because the cell membrane is lipids. So that is why we need the unionized portion to be more. Now we can see the ionized portion by unionized portion. pH is equal to pKa. Where these are 50-50, this will be same. Now this is not going to change. Lignocaine pKa is 7.8. Bupivacaine is 8.1. Now you see lignocaine pKa means 50%, 50% ionized, unionized. This is close to physiological pH than this. That is why it is getting a faster onset. I will come back in another slide. Now you see we are in the syringe. This syringe has got lignocaine hydrochloride and a pH of 6. Now you see 1% is only here. Now the salt ionized portion is some 99%. Now you drop the solution into the nerve fiber. There the tissue pH is around 7.4, where it becomes 24% is, here you can see 24% is unionized. It enters because it is lipophilic. Now here inside the cell, the tissue pH is little acidic, 7.3. So more amount of active or the ionized portion will come. It will block from inside the cell the sodium receptor, and this conduction is blocked. Now you see the unionized lipophilic portion is necessary for cellular entry, and after that, that is not going to take part in the blockade of the sodium channels. The active portion is going to be ionized, but ionized cannot enter. It has to block from inside the cell. That is what happens inside the cell. The ionized is more and easily blocks. There may be other factors. The pKa is one factor, 7.8 lignocaine, fast onset. If it is going to be the site, where is the site? It's going to be spinal, epidural, blocks, so whatever it is, where you are giving, that also matters. Lipophilicity matters. Strength of a solution matters. If you are giving 0.75% ropivacaine or 0.25%, that also matters. Potency. All these also matter in onset. But what matters is a pKa close to the pH of the body. Now, chlorprocaine is an exception to the rule. The chlorprocaine has pKa of 8.7, see, greater than everything. But it has got a fast onset because we are giving a heavy dose of the drug because it is safe. We are giving very heavy dose of the drug. That is what I told. Where you are giving, how much you are driving, how much is the potency also has an influence on the onset. That is what chlorprocaine does. It is very safe cardiac. It is very safe neurologically. So give a lot of drugs so improve the onset. Because it has a low risk of loss. That is what is very important in chlorprocaine. If we add sodium bicarbonate, what happens? The lipid soluble form will be more in the syringe. If you add more, there will be 80-90% lipid soluble form, and you can see white color precipitation. That is what happens. Now it becomes not water soluble, it becomes fat soluble, fats precipitate. So you have to add 0.1 ml per 10 ml of bupivacaine or 1 ml maximum per 10 ml of lignocaine. So that what is the difference. If you add more, precipitate, no use. Now what happens if we add soda bicarb? Now if you add soda bicarb here, the pH itself here is not 3 or 4. Now if you give, it's around 6 or 7 it becomes. Now if you give a 7 or 6 pH, or 6.5, automatically the unionized portion is very high. It will enter fast here, while the pH is 7.3 and acts fast. So the unionized portion, instead of 24, because we have added soda bicarb, it may be around 40, 50. So automatically this becomes, why I say, if you add soda bicarb and make a pH of 7.8, lignocaine 50-50, because it is pKa of lignocaine. The pKa is not going to change if you add lignocaine, if you add adrenaline. The drug has got this pKa. It is not going to change. Now, if you add soda bicarb, you are getting the drug's pH too close to pKa. So it is 40%, 50% of the drug will be lipid soluble instead of this 24%, and easily it can enter the cell. And that is why if we add soda bicarb, the onset is faster. Now you see lignocaine is 4.6. Lignocaine is adrenaline is 4. That is why I am not very interested in using this combination, lignocaine with adrenaline. I want to use, I take this and add 2 drops of freshly prepared adrenaline. So the pH remains 5 and not 4. The pH remains 5 and not 4. And if we add this, because this is 4 and bupivacaine is 6, if we add, we don't know what is the pH, the bupivacaine is going to come down. That is why I am not very keen in this combination, especially if you want to put, you put here 0.5% or whatever it is, adrenaline if you want, but this is not much useful because I'll come later. So that is why the pH changes. Unless you have a control over the pH, you cannot determine the onset. Now you see if the pH is acidic here. Now if you are in an anaerobic environment full of pus, you are injecting here. Now this is an abscess and you are injecting local anesthetics. Here the pH is very low and your unionized lipophilic portion, instead of 24, maybe only 5%, and it will not enter the cell. That is why local anesthetics are not efficacious in pus areas. pH is acidic in those tissues. The unionized portion or the lipophilic portion is less. So the cellular entry is less. So the action is not comfortable and it is not useful in clinical terms. Local anesthetics are made as hydrochloric salts. The pH is around 4. But we don't want that. Make it as a carbonate salts. It may be higher. The advantage is higher pH. No close. No, much of the lipophilic portion will enter. And the carbon dioxide sometimes may be released inside. There we become acidic. There we want more ionized portion, which is active. That is what is the advantage of carbonation. Not only single. First carbonation, the pH is high, lipophilic portion is more, entry. And after that, carbon dioxide diffuses inside the cell and the cellular pH is less. Ionized or active portion is more. It goes from inside the cell and blocks. This is the advantage of carbonation of local anesthetics. Now, carbonated local anesthetics in subclavian perivascular block is to be very effective and duration of the anesthesia. Now, conformations of the voltage gated sodium channels. It can be either resting or activated or inactivated. Inactivated closes slowly. It opens fast. If you give a drug here, it may not be useful. If you give a drug here, it will be okay. And if you give a lignocaine here, sir, it will enter. And all these things enter into the here, enter and then block this. The advantage is if you have activated sodium channels, it can be blocked easily. That is the biggest advantage. So if you want to block certain portion, get into this position. Phasic block or rate dependent block. The binding of local anesthetics to open sodium channels increases with the frequency of nerve depolarization. This is known as use dependent or phasic block. I am coming back again now. Now we have given spinal. Okay, we want herniorrhaphy. The level is T12. We are worried. Now, what you do is you do a pinprick in these T10 and T9 areas. Tuck, 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 tuck. Slowly you do pinprick. Now, what we are doing in this pinprick is, if you do a pinprick in these areas and patient is getting a mild pain, then what happens is these areas, nerve cells will come into activated state. Activated states absorbs your bupivacaine or lignocaine and gets blocked. So this is what is called phasic block. Many times I use this whenever I want T6, tuck, 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 prick T6, those channels will open. This is what is called phasic or rate dependent block. Get the channels to this state. This is tetrodotoxin is not from down. It blocks the tetrodotoxin from sodium channels and only from outside, and it is due to binding to the selectively filter, resulting in prevention of sodium ion flow. That is why some say this TTX is stimulated when you have a scorpion sting, and this is getting blocked. So repeated attacks of scorpion sting can get these channels into disarray and sometimes cause local anesthetic resistance. Now, local anesthetics bind to sodium channels in open position from inside, block sodium entry, prevent depolarization and conductance, and goes into inactivated state and later resting state. Back again, if you give the drug, come back to the active state. Now, what is use dependent block? That is what we have told. Now, what is the duration? Now we have told about onset and duration next. Duration is approximately related to protein binding. A highly protein bound drug, high duration of action. Very simple. But high protein binding is one of the projected reasons for increased toxic effect of bupivacaine. It gets into the cell and it doesn't come out. Local anesthetics with high protein binding have a longer duration of action and a lower bioavailability. Hypoxia, hypercarbia, acidemia decrease protein binding and increases the risk of toxicity. So as soon as you think you are having some toxic problems, don't allow hypoxia, hypercarbia and acidemia. So if you correct this, your protein binding is okay at least. When used without vasopressors, lignocaine shortens its own duration by dilating locals, whereas bupivacaine is not much. That is why if you add adrenaline to bupivacaine, it is not much useful. It is not because bupivacaine itself is long duration. Bupivacaine has got very minimal intrinsic local uh, vasodilatory properties. Lignocaine vasodilates. If you add adrenaline, that is gone. So duration is prolonged. But bupivacaine doesn't vasodilate. Adrenaline may be useful in certain other terms, but it is not much useful in prolonging the duration. The duration of action of the drug is also related to its structure, the length of the intermediate chain, the joining of the aromatic and amino acid groups. So what we know, the onset is pKa, potency is lipophilicity, duration is protein binding, OPD, PLP. Onset pKa, potency lipophilicity, duration protein binding. The order and ease of blockade, preganglionic, pain temperature, touch perception, then motor, because size and myelination. Now, one thing, myelinated nerves gets easily blocked because we know saltatory conduction. And in the myelinated nerves, the smaller nerves get blocked easily. Unmyelinated nerves, small size is not there. Myelinated nerves, small size, block first. That is what is the thing. Now the preganglionic B type fibers block first, autonomic. Then you get A delta. Then you get all these things. Then lastly we get C fibers. That is why autonomic, sensory and motor. But sometimes if you are giving an ultrasound guided blocks topically, or sometimes we don't know exactly, it doesn't come. This is supposed to be there because the autonomic nerve fibers are smaller, but if you give high dose, sometimes sensory also comes very fast in spine. Chiral drugs means asymmetric carbon atom. Carbon has got 4 valencies. All the 4 valencies are being given some other different combination of elements. Then it is called asymmetric carbon atom. This has got an enantiomeric action. I will come to isomerism and anesthesia in a different video. Sodium channel, I already told, tetrodotoxin and scorpion sting. What is minimum concentration of blocking nerve fibers? Is called CM. Nodes of Ranvier. You need to block 3 nodes of Ranvier. In vitro studies have proved that 4 millimeter of the nerve need to be blocked if you want these things. But see here, saltatory conduction from here to here. This is what is in myelinated nerves. That is why if you block 3 nodes of Ranvier, your conductance is blocked, and if you pinch in the umbilicus, the patient will not have pain. Sensory anesthesia sufficient for skin incision cannot be completely obtained without minimal motor input. But if we have a local anesthetic that blocks only A delta and C fibers, but not A alpha or A beta, then it is great. Then this is what is called differential block. Now, what is already told, phasic block or use dependent block previously. That means what? If you pinch in the T10, automatically the channels will come from resting state to activated state, and the local anesthetic will go there. That is what is called phasic block or use dependent block. Now, what is differential block? Sensory is blocked, but motor is not there. Etidocaine more towards motor. Ropivacaine more towards sensory. This is what is called differential block. Now, ropivacaine is more sensory. Levobupivacaine is okay. Bupivacaine. Then etidocaine is more towards motor. A differential block for nerve functions, differential sensitivities. This is well proven in neuraxial and peripheral nerve blocks. So very simple is about labor analgesia. We are using this. We are using 0.15% bupivacaine to get the sensory and not the motor. That is the basics. Differential block is the base of walking epidurals. Now the same thing is repeated, inactive, resting, and all these things. Other actions on the vasculature, they have antiarrhythmic response, they blunt intubation response, they have actions on neuropathic pain. Distribution is about lung extraction, skeletal muscle maximum, and metabolized by xyridides and excreted in the urine, amyloglycols. A specific local anesthetic is associated with methemoglobinemia, that is what is prilocaine. And the alkylation of the tertiary amine in lignocaine. That is important, where the ester local anesthetics undergo PABA. Local anesthetics may be combined in an effort to produce rapid onset. The toxicity of combination is additive, very important. We are giving 3 milligram per kg of the bupivacaine and 7 milligram per kg of lignocaine, and add both and then give, patient may land up in toxicity. I will give in another, I've already clearly told in another video of last. Danger of allergy, usually in ester PABA, or otherwise it may be due to additives and preservatives. Due to local alone is extremely rare. There are numerous routes: epidural, intrathecal, intrapleural, articular, intramuscular, perineural, topical, infiltrative, action different, dose matters, IVRA. What is EMLA? An eutectic mixture of 2.5% lignocaine, 2.5% prilocaine. When you appose, the anesthetic depth may up to 5 millimeters. The onset may be 45 minutes if you scratch here, and you have to wait for 45 minutes. When the effects take place, the vessels may show vasoconstriction initially, may be followed by vasodilatation. So that is why there is one more advantage of having vasodilated skin little later, so that the IV access is easy, not only because of pain relief, but also because of an intrinsic vasodilatation by the local anesthetics. Although many other topical local anesthetic products are available, the skin do not permit to reach the nociceptors. That is what is important. This can Foley's catheter be put. Jelly the nasal mucosa we put. Airway nasal oral mucosa we put. In skin, we cannot put because the nociceptors are under the stratum corneum. And if you paint the local anesthetics, it will not reach the nociceptors. As soon as you put the knife, yes, the patient will have pain. That is the disadvantage of this thing. What EMLA does, melting point is decreased. The lignocaine is 868, prilocaine is 160. If you get EMLA, then it is only 18. That is the advantage. Melting point decreases in this thing. This eutexus phenomenon is not in medical. It was for the metals to make different alloys to decrease the melting point. But this came into the picture of local anesthetics to create EMLA. Neuropathic pain, yes, they are injected in targets. They can be administered. What I use is 100 milligram in 100 ml in 30 minutes to run and for 5 days. Now we have local anesthetic history. Cocaine paste and put it in 3 portions. We have amide or the intermediate. This year benzene, that year is an amine. So in between ester is an ester local anesthetics. Amide is a local amide local anesthetics. Amide has 2 I's. Onset is pKa. Duration is protein. Potency is lipophilicity. Metabolism, ester local anesthetics get into para. And your amide local anesthetics ND alkylation by the liver and lung extraction also into xylodides and excreted. Nerve fiber size, lower the size, easier the attraction and loss of depolarization. Myelination, yes, nodes of Ranvier 3 millimeters. Sensitivity. Sodium channel already I have told, go in and block.